Hello, everyone, and thank you very much for watching this. I'm Dr. Alice Cheng, an endocrinologist from the University of Toronto, and it's my pleasure to be moderating this video talking about some very exciting breaking news from ACC 2025, specifically talking about the STRIDE study and the novel therapy of semaglutide as a novel treatment for peripheral arterial disease. And I'm happy to be joined today by two prominent professionals who will be able to speak eloquently about this clinical trial. Specifically, we have Dr. Subodh Verma as well as Dr. Marc Bonaca. So welcome to both of you, and maybe I'll have each of you introduce yourself, and perhaps I'll start with you, Subodh.
Well, thank you, Alice. Really glad that you're moderating this very exciting paper. I'm Subodh Verma from the University of Toronto. I'm a cardiovascular surgeon and professor of surgery and pharmacology, and I had the great honor of really co-leading this with Marc, who and we just presented these data as you've heard at the American College of Cardiology. The data are now available as well in the Lancet. Marc?
Yeah, thank you. Honored to be here. Marc Bonaca, I'm a cardiologist and a vascular medicine specialist at the University of Colorado. And I'm also the executive director of CPC, where we core lab some of the functional outcomes for the trials. And really pleasure to be here today learning about the results.
So as you can see, we've got the two perfect people to be telling us about STRIDE. So I'm going to start with you, Marc. Can you explain to us what was the rationale for doing this study at all? What was the question that needed to be answered? What was the unmet need?
Yeah, thank you. This is a challenging space. We don't often see PAD trials in national meetings like this, and in part that's because it's such a morbid disease, and it's been difficult to find novel therapies. So, the last approved drug we've had for peripheral artery disease was almost 25 years ago. Despite that, there are over 230 million individuals globally that have lower extremity PAD that suffer really the dominant morbidity of functional limitation, the inability to walk. They're severely disabled, and progression of disease often leads to revascularization procedures, and then down the road, adverse limb outcomes leading to acute limb ischemia and amputation. So this is one of the most morbid manifestations of atherosclerotic vascular disease, and particularly in the patients who have diabetes that tend to have disease below the knee, small vessel disease. We don't have good options. Sometimes they're not revascularization candidates. We don't have many medical therapies, and so there's really a huge unmet need here. And Dr. Verma will talk about some of the promise of these novel therapies, but there's been a lot of attempts, a lot of trials looking at novel therapies that have failed here. But because of the multifactorial nature of disease, the inflammatory component, the microvascular component, and so on, we haven't had an effective therapy.
So then, Subodh, the compound that was studied was semaglutide, which of course is a GLP-1 receptor agonist, which in and of itself is not novel. However, its use in PAD may in fact be novel. So why GLP-1 receptor agonists in this space?
No, you're absolutely right. I echo what Marc said, and that is that we've had several attempts right over almost a quarter of a century trying to find solutions for this recalcitrant problem, and we just haven't had any. And as you know, as an endocrinologist, Alice, there was also controversy around some of the SGLT2 inhibitors. At some point in time, around their potential limb safety. Now, of course, that was put to rest, but suffice to say that just treating diabetes per se has not necessarily made huge differences in the impact of the outcome of peripheral arterial disease. And in our province, where you and I come from in Ontario, data led at our institution has shown through the ICES registry that, in fact, rates of limb loss and amputations in people living with diabetes have actually been on the rise over the last decade. So, this is a huge problem. Now, GLP-1 RAs, as you know, semaglutide and its brothers and sisters, as we call them, the G network and double G and triple G and quadruple G, really have emerged as powerful tools in the treatment of overweight and obesity and diabetes. We did a recent trial in heart failure with preserved ejection fraction, which showed benefit. You're involved in a leadership role in many of the sort of evolving therapies in this space in atherosclerosis. But I think one of the tipping points for the field was the SELECT trial. And the SELECT trial really ushered in hope that this may truly be an anti-atherosclerotic strategy. Semaglutide was used in people living with overweight or obesity who did not have diabetes per se and had a BMI of over 27, and major adverse cardiovascular events went down. And that was the sort of, I think, proof that these drugs could be anti-atherosclerotic, reducing primarily ischemic cardiovascular events, heart attacks and strokes. At the same time, we've had a lot of data from the heart failure arena and others suggesting that this class of medications is anti-inflammatory, reduces CRP, reduces inflammatory signals, etc. May also have effects to modulate the innate and adaptive immune system favorably, and actually has hemodynamic effects, right? Effects to improve, lower blood pressure, etc. And you've also heard, again, data suggesting that it actually has a potential role also on addictive behaviors, particularly behaviors linked to smoking and alcohol ingestion, etc. And people living with PAD face a number of these risk factors: systemic inflammation, dysregulated immune activation, high rates of smoking, overweight, obesity, of course, type 2 diabetes. And therefore, in the context of a clinical trial result like SELECT that suggested they may actually have effects to reduce atherosclerotic events, we thought it was reasonable to test the hypotheses that in a patient population with PAD, which really, as Marc said, is a manifestation of systemic atherosclerosis, there may actually be a potential to improve outcomes here. We were also very fascinated by the STEP-HFpEF result, because that came in during the conduct of STRIDE. It actually suggested that functional outcomes could actually, in people with heart failure, could be improved markedly with this therapy. And that was sort of, the rationale. There was no direct anti-atherosclerotic mechanism per se of semaglutide that we said would be in the direct causal pathway that would be important to interrogate here. But I think it is more of a holistic sort of pharmacological approach targeting many of the risk factors that are causally linked to the pathobiology and natural history of PAD.
Okay, so sounds like PAD is bad, lots of bad outcomes. PAD
Yeah,
is common. We
yeah.
didn't have a lot of treatments to offer before this. And certainly in the diabetes space, I see a fair bit of PAD. So then it made sense to try a GLP-1 receptor agonist. So Marc, let's not keep them waiting. What
Yeah.
did you find?
Yeah, and maybe just to walk a little bit through the design, we actually designed the trial, started enrollment in 2020. And just to add to Dr. Verma's comments, that was on the heels of LEADER. And there were outcomes results. We knew there was a potent anti-inflammatory effect of these agents with liraglutide, and there was actually a paper that looked at a lower rate of amputations in patients with diabetes. So just as Dr. Verma said, I think there was good rationale. And if you ask me, I think that the anti-inflammatory effects are a core driver of PAD progression that haven't been addressed with other agents, but multifactorial, as Dr. Verma said. So in 2020, around 20 countries were involved, and this is a functional outcome study, just as Dr. Verma said. So we used a constant load treadmill test. This is really a gold standard test for regulatory approval for function in PAD. And we used an outcome called the maximal walking distance. So different than the 6-minute walk, which is a speed test. This is a true distance test where people walk around 2 miles per hour on a 12% grade. And then we, pre-specified a whole host of other outcomes to support whether, a change in maximal walking distance is important. So we looked at symptoms in terms of pain-free walking distance. We looked at patient-reported outcomes and hemodynamics, as well as other markers, as Dr. Verma said. So overall, we recruited around 800 patients, which is large for a trial with this type of endpoint. They all had to have symptomatic PAD, so early stage claudication, Fontan class 2A, which is the earliest symptomatic stage, and diabetes. Otherwise, not a lot of inclusion exclusion. And then patients were randomized to the semaglutide 1 milligram weekly dose versus placebo, and then followed for 52 weeks. And overall, we found that treatment with semaglutide significantly improved maximal walking distance. And this benefit was apparent even at 6 months, and then continued to grow over time. In terms of magnitude, when you think about different disease states, what's the magnitude of effect? The median increase in distance was 26 meters, and the mean was 40 meters, which is, what has been demonstrated, or better than what's been demonstrated with what are now class 1 guideline medicines that aren't well tolerated and don't have other benefits. And so that's a large magnitude of effect. And then I think what's really remarkable about STRIDE is that every confirmatory, supportive, and exploratory secondary and exploratory outcome was positive. Semaglutide improved symptoms in terms of pain-free walking distance. It improved the VascuQoL, which was the PRO that we pre-specified. It improved the physical function module of the SF-36. It even improved the ankle brachial index, which is something we've not seen before with another mechanism. And then when we, explored clinical outcomes like progression requiring rescue revascularization, adverse limb events, and mortality, we saw, an odds ratio or hazard ratio of 0.46, almost a halving of events that nominally met statistical significance, even though this was a, post hoc outcome. Certainly very exciting to see that all of these things demonstrate that there's a clear, very clear, important benefit of semaglutide on all of the outcomes. And, we even tried to understand a little bit of what was driving this, and we can get into this a little bit more in the discussion, but we saw all the beneficial effects you'd expect from semaglutide, including about a 4 kilogram net weight loss. But when we looked at the correlation of outcome and weight loss did not explain. It was very, very weak. It did not explain the magnitude of benefit that we saw. Getting to mechanism, which is clearly all of these things, blood pressure, A1C, weight, come into play, but they don't explain the benefit that was observed. And I think, that's an area for future study.
Impressive, very impressive results, and people felt better, which I think is powerful, and they walked farther. I mean, these are, they sound so simple, but things we take for granted, but yet someone living with PAD obviously cannot. So Subodh, what are the clinical implications of this? How do you interpret this?
I think this is a new day for people with PAD. It's we've been waiting for, as Marc said, a quarter of a century. This ushers in hope for people with diabetes living with PAD. I think the core messages are five. Number one, as we all know, PAD is underdiagnosed. Often we catch it in people with diabetes when it's a bit too far, and we have very little options. So this should first and foremost raise awareness around, the importance of screening for PAD in people living with diabetes. That's number one. Number two, I think we need to recognize the fact that this is not just a therapy to improve limb outcomes or walking distance in people living with PAD. Marc and I and others have already shown that in people living with diabetes who have PAD, they derive greater MACE reduction from semaglutide. So we have that data set from SUSTAIN 6. So we know that now we've got a strategy in people living with PAD that can reduce MACE events, arguably to with greater absolute risk reduction given the higher baseline risk in people with PAD. And now we have a strategy that can also improve functional outcomes in PAD with a very tantalizing result that it could reduce sort of the progression of disease from mild to more severe forms, i.e. requiring progressive decreases in ABI being attenuated, or rescue revascularization or rescue medications, or even all-cause mortality. Of course, we're not powered for that exploratory outcome, but it is, I think it's really remarkable that a population of patients that often does not receive the same level of care as many other patients with atherosclerotic cardiovascular disease do. Who would have thought that this medication, and this class of medication would actually transcend from being a strategy for, A1C to overweight, to so much more. So as I tell my fellows, the story of semaglutide, at the heart of semaglutide is much more than weight. And certainly I think this has reminded us about that.
So where do you go from here, Marc? What are next steps?
Well, thank you. Yeah, it is so exciting. I think, Subodh said this is a huge achievement, and we have a new treatment for PAD. I mean, that's a wonderful place to be. That being said, I think there's more to learn. For example, we see from SELECT that the benefits of these agents aren't restricted to those patients with diabetes. And in STRIDE, we did restrict it to PAD and diabetes because it's a particularly challenging population. But I think future studies should involve patients with PAD who don't have diabetes. In addition, as Dr. Verma said, we tackled a very difficult problem, which is functional limitation and symptoms. That being said, we saw a very tantalizing signal towards outcomes benefit. And I think a future trial, a larger, longer trial to really demonstrate what the outcome or benefit for MACE and for major adverse limb events in this population, with and without diabetes, would be a landmark trial for the field. And really, I think would tell us that GLP-1s are vascular drugs, at least for the patients who suffer from PAD.
I mean, GLP-1 receptor agonists were born in the diabetes space, right? So sitting here as an endocrinologist, it's kind of where they started as glucose-lowering agents, but they've really grown up and moved out and made friends elsewhere and really belong in multiple therapeutic areas. And that thought of it being a vascular drug, I think, is more and more data accumulating to support that. And in this population with peripheral arterial disease, that I definitely see in my clinic. And as you've alluded to, we have not had anything really substantial to offer them to now be able to say, hey, there's something I can now offer you where you're going to feel better and be able to walk further. I think from a patient perspective, is really very powerful for things we've taken for granted. But I 100% agree that I would love to then be also to be able to say to them in the future, if the data support it, that this is also going to reduce amputations or save limbs. And I think having those hard outcomes is going to be really game changing, for many reasons. So I think I look forward to seeing those data when they become available. But this is really wonderful news for people living with type 2 diabetes and living with peripheral arterial disease. So thank you, gentlemen, for doing the study, you and your colleagues, and thank you very much for sharing your expertise with us today.
Thank you, Alice.
Thank you, Alice.